So, greetings and a warm welcome to all the dignitaries present here. I'm Sreushi from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarinet serves as the digital partner for this event hosted by the Indian College of Anesthesiologists. And the focus of today's session is update on basic monitoring in anesthesia. So let's begin today's session, for which I would like to invite Dr. Muralidhar Kanchi sir to take over. Over to you, sir.
Thank you, Shreyasi, for that kind introduction, and we really appreciate your help in conducting these webinars very seamlessly. Thank you so much for joining us. And it's my great delight and pleasure to welcome you to this ICA webinar, which is hallmark of ICA. ICA stands for Indian College of Anesthesiologists, which was conceptualized and registered in the year 2008, and it has grown from there from strength to strength. And currently, it conducts the webinars on every Wednesday between 7 to 9 p.m. Indian Standard Time without fail. And this has become very popular activity of the Indian College of Anesthesiologists. We have had several prominent faculty participating in this webinar, both from India and abroad, and it has been marked by its quality and the precise information it provides, and it has become a valuable tool for both practitioners as well as trainees to imbibe some sort of knowledge from these webinars. These webinars are also uploaded onto the YouTube when after about a week after the delivery of the live webinar. And I'm grateful that today we have the faculty from Akash Medical College, Bangalore, joining us to deliver and moderate the today's webinar. And I'm grateful to Dr. Kodandaram and Dr. Nagaraj, who are going to be the pillars of this webinar. Dr. Kodandaram and Dr. Nagaraj, both of them are professors of anesthesia in the Akash Medical College. And I think Dr. Srikantamurthy also will be joining, who is the professor and HOD of subject of anesthesiology at the Akash Medical College. Thank you so much for joining us. With these words, today's topic relates to an update on basic monitoring which used in anesthesia on a day-to-day basis. And I request Dr. Kodanram to take over and introduce the first speaker. And I would like to take this opportunity to invite and thank Dr. Srikantamurthy for joining us.
Thank you,
Doctor,
sir.
thank you
Thank
so
you.
much for
Thank
joining us.
you.
Please
Thank you, sir.
invite
Thank you.
at the end so that you can contribute to the discussion. Thank you so much. Over to Dr. Kodandaram. Dr. Kodandaram, are you there? You will have to unmute yourself, Dr. Kodandaram. Please unmute and speak. Yes.
Have I heard now?
Yes, yes.
Yeah.
Good
That's
evening.
right.
Good evening, everybody. The first topic for basic monitoring today is on pulse oximetry. This will be conducted by Dr. Srinivas. He is Professor of Anesthesia at Akash Medical College. Dr. Srinivas, please.
Yes, sir. Hello. Good evening, everybody. Sir, am I audible, sir?
Yes, you are. You are.
Yes, Dave, we can hear you. Thank you.
Good evening, everybody. I'm Dr. Srinivas, working as a professor in the Department of Anesthesiology, Akash Institute of Medical Science, Devnali, Bangalore. Today, I'm doing a presentation basically in monitoring and anesthesia, the subtopic being pulse oximetry. My guide is Dr. Srikant Murthy, sir. To start with, let's look into the great contributions done to the field of pulse oximetry and its history. In 1935, Karl Matz developed the first device to measure oxygen saturation continuously using two wavelengths of light. In 1940, Glenn Millikan coined the term oximeter. In 1972, Takuo Oji, the father of pulse oximetry, invented the technique of the pulse waveform to isolate arterial blood. In 1974, Nihon Koden developed the first commercial pulse oximetry. In 1981, Dr. William New, anesthesiologist and engineer, popularized the device in anesthesia, introduced the variable pitch beep. In 1986, the ASA endorsed pulse oximeter as a standard of care. In 1995, Nonin Medical created the first all-in-one fingertip sensor. I'll be covering this topic and the following headings. First is why SpO2 monitoring? What does SpO2 measure? Oxyhemoglobin dissociation curve, Beer-Lambert's law, importance of pleth wave, clinical applications, limitation, and advanced pulse oximetry. Why SpO2 monitoring? It is an essential component of Association of Anesthesiologists Great Britain and Ireland, ASA, ISA, and World Health Organization monitoring standard. It provides a real-time estimate of patients' oxygenation. It signals need for early intervention. And it also gives us an idea of early detection of hypoxia, airway obstruction, hypoventilation, equipment disconnections. Improves patient safety and reduces perioperative morbidity as well as mortality. What does SpO2 measure? It measures the percentage of hemoglobin binding sites occupied by oxygen. Each molecule of hemoglobin will have 4 units of heme, having 1 atom of iron, which has the capacity to bind to 1 molecule of oxygen, which makes it oxyhemoglobin. And it reflects arterial oxygen saturation, and most importantly, it's a non-invasive method of monitoring based on oxyhemoglobin and deoxyhemoglobin absorption. And as we see in the picture here, in the pulse oximetry, we have an emitter which sends the IR radiations at 2 different frequencies. One is 660 nanometer and 940 nanometer, which is absorbed by 2 different forms of hemoglobin, that is oxyhemoglobin and deoxyhemoglobin. Every liquid has a property to absorb light to some extent, depending on the concentration of the liquid and the kind of liquid. And rest of the light is emitted, which is received by the receiver on the other hand. Based on the difference between the amount of IR radiation which is absorbed and which is emitted to the emitter, we get a reading on the monitor, which gives us an idea about the oxygen saturation. Oxygen saturations, yeah. Now we look into oxyhemoglobin dissociation curve. Now we look into oxyhemoglobin dissociation curve. Oxyhemoglobin dissociation curve determines relation between SaO2 and PaO2. Steep portion, small PaO2 drop will cause large fall in SpO2. As we see in the diagram here, PaO2 is marked on the x-axis and oxygen saturation of hemoglobin is marked on the y-axis. As the oxygen saturation increases, there is no linear relationship between the PaO2 and SpO2. As the oxygen saturation increases, there is a rapid increase in the SpO2 levels. And after between 80 to 100, slowly it will go close to the plateau. And the maximum oxygen saturation level that we can reach is 100% and not beyond that. So the oxygen dissociation curve is basically a sigmoid curve and it is not a linear curve, which gives us an idea about the clinical significance that as the oxygen partial pressure of the oxygen increases, there is a rapid rise in the oxygen saturation levels in the blood also. And the vice versa is also true in the sense, as the patient starts desaturating, initially it takes time for the patient to desaturate between 100% to 80%. And once it falls below 80%, there is a rapid desaturation. It holds good for both adult patients, pediatric patients, and neonates. And the rapid fall in desaturation is much more in pediatric and neonate age group. The reason being, one is low FRC, and the other reason is the sigmoid pattern of fall in the saturations. This is the actual reason we have to be very careful while monitoring oxygen levels perioperatively or in ER department or in critical care as well. The initial phase of desaturation is the time that we have to react and respond very fast, and we have to manage the airway. In case if we don't do that, then there will be a rapid desaturation, and it becomes difficult to manage the airway and the blood gases. And eventually it can cause the hypoxic brain damage or hypoxic damage to both the peripheral and the central compartment and viscera. The key factors that shift the curve. As we see in the previous diagram, this shows the normal ODC curve, and then there can be shift of this curve both to the right and to the left. The right shift mainly means decreased affinity of oxygen to the hemoglobin, and left shift means increased affinity of oxygen to the hemoglobin. Now we'll see the conditions, what causes the right shift, that is increase in the temperature. Increase in the temperature, whenever the body temperature increases, basically the basic metabolic rate increases. Hence, there is increased oxygen demand. That is the actual reason. That is the actual reason. There is decreased affinity of hemoglobin to oxygen, and then there is a shift of oxygen from the vascular compartment to the tissue because the demand is more in the tissue side. And next is increase in the CO2 levels. Whenever there is an increase in the CO2 level, there is a right shift of ODC curve. I mean, the affinity of hemoglobin to oxygen will decrease. Hence, there is a shift of oxygen from the vascular compartment to the tissue because there is more demand in the tissue side. And this is also called as the Bohr's effect. Next is the pH values. Decrease in the pH value in the sense acidity. Any acidic pH will cause decreased affinity of hemoglobin to oxygen, and the vice versa is also true that any increase in the pH, that is alkalosis, will increase the affinity of hemoglobin to oxygen. Then is the 2,3-DPG levels. Increase in the 2,3-DPG levels also decrease the affinity of hemoglobin to oxygen, that is the shift of oxygen from vascular compartment to the tissue side. Now we'll see the causes which causes the left shift of ODC curve. First is hypothermia. As I explained before, in hypothermia, the basal metabolic rate is less, so there is less demand for oxygen at the tissue level, both in the central and the peripheral compartment, and that is the reason there is a left shift in the sense there is more affinity of hemoglobin to oxygen and less shift of oxygen from vascular compartment to the tissue. And as I've explained before, alkalosis is another cause, and carbon monoxide poisoning also. Shift of the legs. Slide shift of the. So this graph shows right shift and left shift of ODC curve. The center one, which is marked in black color, is the normal ODC curve. Left shift, I mean the blue colored curve, is the left shift, which is caused by increase in the pH, decrease in CO2, decrease in 2,3-DPG levels, and decrease in the body temperature. And the right shift is represented by a brown color ODC curve. That is called right shift of ODC curve, which is caused by decreased pH, increased PCO2, increased 2,3-DPG, and hyperthermia. The lag between Time lag between PO2 and SpO2 caused by sudden apnea. SpO2 drop is delayed by 30 to 90 seconds. Faster in children, neonates, and it is slower in adults. Reason because of limited functional residue capacity. Early warning signs of pulse oximetry: damped pleth, low perfusion index, delayed SpO2 drop, searching signals. These appear before hypoxemia. Pulse oximetry, the core principle. Pulse oximetry is based on the Beer-Lambert's law, which means amount of light absorbed depends on the concentration of the absorber and the path it traverses. Two wavelengths of lights are used. One is 640 nanometer, which is absorbed by the deoxyhemoglobin, and 940 nanometer, which is absorbed by the oxyhemoglobin. Microprocessor calculates the ratio of pulsatile to non-pulsatile components, giving SpO2 reading on the monitors. Beer-Lambert's law. This indicates how pulse oximeters work due to hemoglobin's ability to absorb light. Basically, any liquid has the property to absorb light to some extent based on the concentration of the liquid and the type of the liquid. Rest of the light is transmitted on the other side, which is received by the receiver. Based on the difference between these two, we get the reading on the pulse oximeter. Let's look into Beer's law. The amount of light absorbed is proportional to the concentration of the light absorbing substance. When the concentration of this liquid or the tissue component is less, there will be decreased absorption, so that the emission of light on the other side will be more. But when the concentration of the liquid or the tissue component is more, the light absorbed by it is more, so that the light emitted to the other end of the pulse oximeter or the receiver is less. Lambert's law. The amount of light absorbed is proportional to the distance or length the light travels. As we can see in the picture, in first picture, the amount of distance that the light has to travel is less. That is the reason the amount of light reaching the receiver on the other end is more. In the second diagram, as we see, the distance that the light has to traverse is more. That is the reason the amount of light absorbed by the tissue or the substance is also more, and hence the amount of light received by the receiver on the other end is less. Types of pulse oximeter probes: disposable and reusable. Transmission versus reflectance. Transmission probes are used on fingers, toes, earlobes, especially in neonates. Reflectance on forehead and cheek. Reflectance probes are useful in poor perfusion, especially in obesity and vasoconstriction. This is a typical diagram showing the different components of the waveform in a pulse oximetry. First, it will show us, first is the systolic pressure, second is the dicrotic notch, then is the diastolic pressure. We can also calculate the mean arterial pressure if we plot the diagram below that. Importance of pleth wave. It shows us the artificial stiffness, arterial stiffness and compliance. Stiffer arteries, less compliance, causes the reflected wave to return earlier and at higher amplitude, increasing the peak systolic pressures. Pulse wave velocity. Direct measure of arterial stiffness. It's calculated using the pulse wave travel time between 2 points and the distance. Left ventricular ejection time, the duration of systole. Cardiac functions. Waveform morphology can reveal deficits related to preload, contractility, and afterload also. Dicrotic notch. Dicrotic notch is a small characteristic dip in or indentation in the descending limb of the central arterial pressure waveform, demarcating systole and diastole. The notch is universally used to signal the moment of aortic valve closure. This event definitely marks the end of ventricular systole and the beginning of ventricular diastole in the central arteries. The notch is formed as blood which was moving forwards during systole attempts to flow back following the end of the ventricular ejection. The rapid closure of the aortic valve halts the retrograde flow, causing a brief drop and then an increase in the pressure due to the elastic recoil of the aorta. Clinical applications of pulse oximeter. It is used for monitoring of oxygenation. Mainly in the anesthetizing areas, oxygen desaturation can happen anytime during anesthesia, regardless of anesthesia provider's skill and experience. Pediatric patients are especially at high risk. Most severe desaturations occur during induction or emergence from the anesthesia. It is also used in post-anesthesia care units or the recovery units, another location where desaturation is common and hence monitoring is very important. Routine oxygen administration to post-operative patients may not be necessary when they are monitored by pulse oximetry. And monitoring with pulse oximeter is very important during transport also. Unrecognized oxygen desaturation may happen to the patient in the meantime of transport, and hence pulse oximetry is very important. Pulse oximetry is included on most transport monitors, and portable pulse oximeters are also available. Patients receiving post-operative opioids, because opioids are also known to cause respiratory depression. Monitoring peripheral circulation. Pulse oximeter can detect limb positions and compromise the circulation. Patients with limb fractures, pulse oximeter may serve as a useful guide for blood flow distal to the fractures. Pulse oximeter may be used to evaluate the effect of sympathetic block as indicated by increased peripheral blood flow. Causes of false high and false low readings on pulse oximeter. False high readings is caused by carbon monoxide poisoning, left shifted Odysseus curve, bright ambient light, and motion artifacts. False low SpO2 levels are seen in methemoglobinemia, poor perfusion, hypothermia, intravenous dyes. And limitations of pulse oximeter. Poor function with poor perfusion, difficulty detecting high oxygen partial pressures, delayed hypoxic event detection, erratic performance with dysarrhythmias, failure to determine the oxygen saturation, small but definite incidence of failure with pulse oximetry, latent phase of oximetry, which is for a duration of 15 to 20 seconds. Reliable reading is between 70 to 100%. Inaccuracy. In different forms of hemoglobin like methemoglobin, carboxyhemoglobin, fetal hemoglobin, HP, hemoglobin S, and self-hemoglobin, bilirubinemia, malpositioned probes, venous pulsations, mixed probes of different manufacturer monitor, severe anemia, optical interference and electrical interference, hypothermia and hypotension. Skin pigmentation, dyes, nail polish and coverings, motion artifacts, pressures on the probe, hyperemia, and probe damage. And different waveforms seen in different clinical conditions. The first one showing the normal pattern of pulse oximeter waveform. Second one indicating low perfusion. Third one showing noise artifact. And fourth one showing motion artifacts. And different form, the variations in pulse oximeter waveform in different clinical conditions. First one showing the normal pattern. Second one seen in aortic stenosis. Third one is in aortic regurgitation, the bifid waveform. And in case of low systemic vascular resistance, we will have a steep downstroke and high dicrotic notch in cases of high systemic vascular resistance. Advanced forms of pulse oximeter. Rainbow pulse co-oximetry reads SpCO and SP Met also. RR oxysensimeters, near infrared spectroscopy, which is used in cerebral oximetry, signal extraction technology minimizes motion error, and transcutaneous O2 and CO2 probes. Key takeaways are SpO2 is essential real-time oxygen monitor, utilizes Beer-Lambert's law and dual wavelengths, contains multiple sources of error. Pulse wave is as important as the number. Always correlate clinically. ABG when values are doubtful. Thank you.
Thank you, Dr. Srinivas. Now I request Dr. Nagaraj to introduce the next speaker.
Am I audible, sir?
Yes.
Yeah, it gives me great pleasure to introduce Dr. Avinash, Assistant Professor in the Department of Anesthesiology. He's on the verge of becoming an Associate Professor very soon. He's graduated from the Rajarajeshwari Medical College and his MD is from the Enipoya Medical College. Dr. Avinash is a versatile personality loved by everyone in the department. He not only is a skilled anesthesiologist, he doubles up even sometimes as a biomedical engineer and repairing snags in the hardware of electromedical equipment. If I may take a few liberties, he is also blessed with great looks and he oozes warmth. And rightly so, he has chosen to speak on temperature monitoring. And I'm sure after that, the warming up session by Dr. Srinivas, Dr. Avinash is going to heat up the session by a few degrees. Over to you, Dr. Avinash.
Thank you for the kind words, sir. Are my slides visible, sir?
Yeah.
Yeah, okay. Good evening, all. This is Dr. Avinash. I'm assistant professor in Akash Medical College, Bangalore. So today I would be talking about temperature monitoring, and I would be telling why it's so important for us to monitor temperature. So what is body temperature? Body temperature is a measure of body's ability to lose or generate heat to maintain hemostasis. And it is measured in degrees Celsius or degree Fahrenheit. Celsius can also be called centigrade. So what is this normal body temperature, what you have to see for? It's around 98.6 degree Fahrenheit or 37 degrees Celsius. And if you have to talk about it in a range, oral temperature is around 97.6 to 99.6. Axillary, that is underarm, it is 96.6 to 98.6. Rectal, that is more commonly done in babies, that is around 98.6 to 100.3 degree Fahrenheit. And ear temperature is around 97.8 to 99.5 degree Fahrenheit. Forehead is around 97.8 to 99.1 degree Fahrenheit. So these are the approximate range of body temperatures which you can briefly remember as 98 degree plus or minus 1 degree and 37 degree plus or minus 1 degree. So what are the factors which affects normal body temperature? So usually in the mornings, the body temperature would be low, and in the evenings, the body temperature would be high. And during any physical activities, the body temperature rises. So after any physical activity, it is better not to rely on that body temperature. In kids, usually there will be a little slightly raise in the body temperature compared to adults. And in women, during their menstrual cycle, there would be a slight increase in body temperature due to hormonal changes. So how does our body maintain the body temperature at that 37 degrees centigrade? So this is a brief pictorial depiction of how it maintains. So you can see this, our body temperature, normal body temperature is around 36.5 to 37, or else you can call it as 37 degrees centigrade. So when our body temperature comes down, the temperature receptors in the hypothalamus stimulate heat-producing mechanisms such as superficial arteries, or there'll be vasodilatation. There'll be vasoconstriction, and then there can be muscle shivering, like the muscles shiver. And sometimes the steroids also stimulate your the body cells to increase the metabolic heat production. And in neonates and babies, usually there is something called as brown fat, so that increases the body heat without shivering. So all these mechanisms slowly increases the body temperature, thereby bringing the body temperature to normal, that is 37, that core body temperature to 37 degrees centigrade. Whereas when it is when the body warms up or heats up again, the thermoreceptors, the receptors which is present senses the rise in temperature, and the hypothalamus, which is the central regulatory system, activates the superficial arteries. So there will be vasodilatation. So there will be the heat goes out to the skin surface, and thereby it gets exposed to the atmosphere, and there will be loss of heat through our vessels. And also the sweat glands are activated, so that sweat glands releases sweats, and the evaporation of sweat cools down the skin, and the arteries which are supplying the skin cools down the blood, and thereby the heat regulation is maintained. So again, there's a brief graph which tells flow chart where thermal receptors activate, and the perioptic nuclei in the anterior hypothalamus activates the cold and heat sensors. So the afferent responses would be cold responses, constriction, shivering, non-shivering thermogenesis, and there'll be behavioral changes. Behavioral changes is also one of the important mechanisms of thermoregulation, where an organism or for example, human being would cover themselves up and raise the body temperature in cold. And during heat response, there will be sweating, vasodilatation, and again behavioral mechanisms where you switch on your fans or AC or whatever methods you can cool yourself down. So by doing this thermoregulatory system, our body temperature gets maintained at 37 degrees centigrade. And there is a threshold in which after which the cold response or heat response activates. So this is called as the interthreshold range, the range of core temperature from first cold response and first warm response not triggering ANS thermoregulatory compensation is called as interthreshold range. So in humans, it is very low, that is around 0.2 to 0.3 degrees centigrade, not more than that. So this threshold range is bounded by sweating at the upper end. That is when the body heats up, it sweats, and the lower end, when the body cools down, there'll be vasoconstriction. These are the first responses in the thermoregulatory mechanism of the body. So why is temperature monitoring so important during anesthesia? See, under anesthesia, there'll be this combination of increased sweating thresholds, and also there'll be the vasoconstriction thresholds also decreases a lot. So this increase in threshold range approximately increases by 20 times. That is the whatever I mentioned in the earlier slide, that is 0.2 to 0.3 degrees centigrades changes to 2 to 4 degrees centigrades. So till the body cools down to more than 2 degree, or the body temperature rises to 4 degree, like more than 4, like that range, our thermoregulatory mechanisms doesn't activate itself. So the body cools down more than what it has to, or most of the time in our OT settings, it'll cool down. Otherwise, due to any other reasons, they can heat up. That we will see in the later slide. So by definition, the patients are poikilothermic within this temperature range. Poikilothermic as in like cold-blooded animals, where the external temperature governs the body temperature. So this is a brief pictorial diagram where it shows during anesthesia, when not during anesthesia, when there is any peripherally, if there is any cold or anything, the body core temperature still is maintained at 37 degrees centigrade because there'll be peripheral vasoconstriction and other mechanisms which are active. But after anesthesia, there'll be vasodilatation. And because of vasodilatation, all blood vessels open up and the core body temperature goes out into the peripherals, thereby heat loss happens. So core temperature reduces. So here it is 36 degree, here it is 37 degree. So this is also one of the diagram which shows normal temperature, which is 37 degree. Like if there is any fall of 0.2 degree centigrade, there will be vasoconstriction. That is the first response to cold. And if there is any heating process going on, the first response to heat is sweating. But whereas in anesthesia, the threshold increases a lot. This is normal 37 degree. So until 34.7 degree, the vasoconstriction doesn't happen. And here in sweating, at least it should reach around 37.8 to 38 degrees for the sweating mechanism to take place. So that is why under anesthesia in the operating room, it is very, very important for us to know this mechanism and act. So as I told you, in the operating room, the most common temperature mishap happens due to hypothermia. So what is this hypothermia? It is defined as body temperature less than 36 degrees centigrade. And unintentional perioperative hypothermia is more common in patients at extreme ages and in those undergoing abdominal surgeries or procedures of long duration. So what are these deleterious effects of hypothermia and why should we be so much worried about hypothermia during anesthesia or during a surgery? There could, because of hypothermia due to many other intricate mechanisms, there can be cardiac arrhythmias and ischemia. There can be increased peripheral vascular resistance. Reversible coagulopathy could happen. There could be platelet dysfunction, hence bleeding can increase intraoperatively. Increased post-operative protein catabolism and stress response, altered mental status, impaired renal function, delayed drug metabolism, and hence emergence can be late because of drug metabolism, shivering and discomfort after the patient is awake, and impaired wound healing also can happen due to hypothermia. And last but not the least, this hypothermia could interfere with the monitoring, but because as Sir told in the previous session, a pulse oximeter reads your capillary blood, but because of vasoconstriction, the blood would not reach the capillaries and the pulse oximeter could not read your pulse and it would not predict your saturation in a proper way. So then these are the few disadvantages of hypothermia. But sometimes this hypothermia can be advantageous also by reducing the metabolic oxygen requirement, and it could be protective during cerebral or cardiac ischemia. So all these things would warrant for monitoring the temperature during operative procedure. Hyperthermia is the opposite of hypothermia, where there's core body elevation of core body temperature, typically about 37.5 degrees centigrade to 38.5 degree, and that occurs without a change in hypothalamic set point. So what are the differential diagnoses of hyperthermia? First and foremost, as an anesthetist, we should know about malignant hyperthermia, neuroleptic malignant syndrome, thyroid storm could have happened, pheochromocytoma drug-induced hyperthermia, serotonin syndrome, and brainstem hypothalamic injuries, sepsis, and transfusion related reactions. So at least the temperature monitoring could alert us if there is any unwarranted, unexpected raise in body temperature during operative procedure. We can quickly at least intervene and find out why it would have happened. So these could be the reasons because for hyperthermia during surgery. So now, how intraoperatively, how do you manage or how do you monitor this patients for temperature? So ASA guidelines state that every patient receiving anesthesia shall have temperature monitored when clinically significant changes in body temperature are intended anticipated or suspected. So if you suspect there could be temperature changes in this patient, so the patient should be monitored for temperature. How do you, so when it should be done? So whenever there are large volumes of cold blood or intravenous fluids are administered, when the patient is deliberately cooled or warmed, pediatric surgeries of substantial duration, hypothermic or pyrexic patients,
Dr. Avinash, your screen has gone off. Yeah.
am I audible? Is my screen
Yes,
visible?
yes. Please carry on.
Yeah, I'm sorry. Was the slide, we could see the slides?
Yeah, continue. Please continue.
Yeah. So the sites of monitoring, the core temperature is done by esophageal, pulmonary artery, tympanic membrane, and nasopharynx. Peripheral, we do it in oral, axilla, and skin, and others are rectum and bladder. So these are special places where we do it for pediatrics, and adults we can use bladder monitoring also. So what are the devices we can use for temperature monitoring? So there are two major devices. One is thermistor and one is a thermocouple. So thermistor is it's a metal which is composed of metal, and it is wired or fused to a rod or bead, and it looks like this. So this due to the temperature, there will be a light change in the atomic structure of the metal as well as the substance which is infused with, and there will be electrical resistance caused inside this device, and that electrical resistance is read by a transducer, and thereby it converts it into temperature. And the second one is a thermocouple, where the two dissimilar metals are welded together, like as in a bimetallic strip. And that based on the temperature, there will be a little fluctuation in the temperature there will be fluctuation in the shape of the metal, and that thereby tells the temperature properly. So this is a thermistor which we use. This is a catheter which we can use for pulmonary artery temperature monitoring. And this is a thermometer where it is, it uses the same concept as a thermistor. There are other devices such as liquid crystal probes. They change color as a function of temperature. It uses thermal optic transmission qualities of a crystal. So as you can see, there is a strip and this is infused with crystals. Based on the heat it receives, it changes color and we can read the temperature. And the last and foremost and the one which is used latest is infrared sensors, where it detects electromagnetic heat radiation from the body, and it is used to measure tympanic membrane and other direct on-skin monitoring also. Like usually, recently we used all these equipments in COVID to detect temperatures in the mass people masses. So now we know how we monitor temperature, and now we come how to manage or how to intraoperatively manage this hypothermia, which is very deleterious to us. So heat losses, as we all know, it is usually by radiation or by convection, conduction, or evaporation. So by radiation, it can be decreased by using double-shelled isolated towels. And heat loss by conduction is reduced by placing baby in a warming mattress or in warming the OT room. Heat loss through convention is minimized by keeping the infant in an incubator or covered in blankets. And heat loss through evaporation is lessered by humidification of inspired gases. So, and we use plastic wrap to decrease water loss through skin. So as per ASA guidelines, so this is also takeaway message. Every patient receiving anesthesia shall have temperature monitored when clinically significant changes in body temperature are intended, anticipated, or suspected. For office-based sedation also and regional anesthesia, general anesthesia, ASA requires body temperature of pediatric patients to be monitored continuously. And body temperature should be monitored in patients having surgery lasting more than 30 minutes, and core temperature should be maintained at 36 degree or higher whenever possible. And forced air warming currently offers best combination of high efficiency and low cost and remarkable safety. So updates, coming to the updates in temperature monitoring, advanced non-invasive continuous monitoring technologies like wearable devices and integration of AI for predictive analytics have come. So we could use them. New guidelines that have expand perioperative temperature monitor management to patients such as malignant hyperthermia. And there is a focus on remote patient monitoring from home health care and automation and variety of applications such as patient care to cold chain management and pharmaceuticals. Thank you.
Thank you, Avinash, for that lucid session. May I now request Keram sir to take over for the introduction of the next speaker, sir.
Thank you. The next talk is on carbon dioxide monitoring. This will be delivered by Dr. Aziba. She is the assistant professor in anesthesia in Akash Medical College. Dr. Aziba, please.
Yes, sir.
Yes, please go on. Slides are seen.
Good evening, everyone. This is Dr. Ajiba. I'm working as assistant professor in Akash Medical College, Bangalore. Topic for today is capnography. And in my presentation, we'll be seeing about introduction, why capnography is important, terminologies, physiology and normal values, physics and types of capnography, components, clinical aspects, and common waveforms. Coming to introduction, capnography is the continuous monitoring of instantaneous carbon dioxide concentration in the respired gases during the respiratory cycle. The measurement of carbon dioxide in expired gases directly indicates the elimination of CO2 from the lungs, but it indirectly indicates the production of carbon dioxide at the tissue level and delivery of carbon dioxide to the lungs. Here, if you see, oxygen is entering the lungs and is then carried by the blood vessels to the tissues. And here, oxygen is converted to carbon dioxide through metabolism in the tissues, and it is then carried by the blood vessels back to the lung where it is then expired. Coming to history, first means of measuring of carbon dioxide in a mixture of air was described by John Scott Haldane in 1905. And in 1939, August Fund developed an analyzer to measure carbon dioxide and carbon monoxide. The modern infrared capnograph was developed by Carl Friedrich Luft, and Holland was the first country to adopt capnography as their standard monitoring. Why capnography is important? It is a part of ASA standards for basic monitoring inside the OT. We have pulse oximetry, which is a direct monitor to reflect the oxygen status of the patient. But capnography, on the other hand, is an indirect monitor. It provides information about carbon dioxide production, pulmonary perfusion, alveolar ventilation, respiratory patterns, and elimination of carbon dioxide from the anesthesia circuit. AAC standards require that correct positioning of the ET tube should be confirmed by identification of EtCO2 and it should be present throughout the general anesthesia. In simple words, if there is no waveform after intubation, it means ET tube is not in place. EtCO2 detects 27% of critical incidents and together capnography and pulse oximetry can prevent 93% of unavoidable anesthesia mishaps. Terminologies. Capnography means continuous monitoring and graphic display of carbon dioxide concentration in the respired gases. Capnogram is the device that generates the carbon dioxide waveform. Capnograph is the device that generates the carbon dioxide waveform, and capnogram means the CO2 waveform itself. Capnometry means the measurement and numeric display of carbon dioxide concentration without a continuous waveform. Coming to physiology, capnography provides information about ventilation, perfusion, and metabolism. In ventilation, it shows how carbon dioxide is being eliminated by the pulmonary system, and in perfusion, it shows how carbon dioxide is being transported through the vascular system, and in metabolism, it shows how CO2 is being produced by the cellular metabolism. Normal values, the normal EtCO2 value is 30 to 40 mmHg, and CO2 concentration in the arterial blood is 35 to 45 mmHg. The difference between the arterial CO2 and EtCO2 is usually 2 to 5 mmHg. And usually if EtCO2 is more than PaCO2, it means either rebreathing is there or FRC is reduced as in pregnancy or in morbid obesity. Coming to physics, there are 5 physical methods. The first one is infrared spectrography, molecular correlation spectrography, Raman spectrography, mass spectrography, photoacoustic spectrography. In infrared spectrography, it is based on Beer-Lambert's law. The amount of infrared light that is absorbed by the respired gas is directly proportional to the concentration of carbon dioxide present in the sample. Here, if you see, this is the infrared light source, and through this infrared lights will be passed, and this is the infrared filter which filters 4.3 micrometer of infrared light to pass through this, and it is then passed through the CO2 chamber containing CO2 molecules. The infrared light will be absorbed by the CO2 molecules present in this chamber. The remaining unabsorbed light will be passed through this chamber, and it will be detected by the infrared detector, which then shows the EtCO2 level. Coming to Raman spectrography, it uses a principle of Raman scattering for carbon dioxide measurement. In mass spectrography, it separates molecules on the basis of mass to charge ratio. Mass spectrometers are quite expensive and too bulky to use at the bedside and are rarely used now. Photoacoustic measurement, it is based on the same principle as conventional infrared based gas analysis, that is the ability of carbon dioxide and nitrous oxide and anesthetic agents to absorb infrared light, but using an acoustic technique. There are 2 types of capnographs, that is mainstream capnograph and side stream capnograph. The picture A shows the mainstream capnograph. In this, the CO2 sensor is located between the endotracheal tube and the breathing circuit, whereas this image shows the B shows the side stream capnograph. In this, the CO2 sensor is placed away from the breathing circuit through a 6 feet sampling line, and the sampling adapter will be present between the breathing endotracheal tube and the breathing circuit. Coming to advantages and disadvantages of mainstream capnographs. In advantages, the sampling tube is not there, so there will not be any obstruction or no delay in recording. It is not affected due to pressure drop or changes in the water vapor pressure. No OT pollution and no deformity of capnograms due to non-dispersion of gases. So it is suitable for neonates and children. Disposable sensor windows, thereby eliminating sterilization problem. Coming to disadvantages, earlier versions used to be heavy, but newer sensors are lightweight, minimizing the traction on the endotracheal tube. Facial burns have been reported with earlier versions. This has been eliminated with newer sensors. There is a long electrical cord, but it is lightweight. Sensor windows may clog with secretions. However, they can be replaced easily as they are disposable. It is difficult to use in unusual patient positioning like prone positions, and it cannot be used in awake or non-intubated patients. Coming to advantages of side stream capnographs, it is easy to connect, no problems with sterilization as it is disposable. It can be used in awake or non-intubated patients, and it is easy to use in prone positions also. It can be used simultaneously along with nasal prongs or oxygen mask also. Disadvantages, there is delay in recording due to the movement of gas from ET tube to the sensor, sampling tube obstruction due to long sampling line, water vapor pressure changes affect carbon dioxide concentration, and pressure drop along the sampling tube affects carbon dioxide measurements, and deformity of capnograms in children due to dispersion of gases in the sampling tubes. Coming to components, there are two components, time and volume component. In time component, pressure is plotted against time, and it displays carbon dioxide concentration against time at two different speeds. One is real-time capnogram and the other one is trend capnogram. In real-time capnogram, a high-speed recording at 7 millimeter per second will be taken. It shows information about each breath. And in trend capnogram, it's a slow speed recording at 0.7 millimeters per second, and it shows overall changes in the carbon dioxide trend. In time capnogram, there are two segments. One is the inspiratory segment that is seen in red color, and the other one is expiratory segment that is seen in green color. In expiratory segment, it has three phases, and phase 1 is the anatomical dead space where the EtCO2 level is 0, and phase 2 is the mixture of anatomical and alveolar dead space. There will be steep increase in the EtCO2 level here. And phase 3 is the alveolar plateau phase where EtCO2 level will be plateaued. There is alpha angle between phase 2 and phase 3. It is usually 100 to 110 degrees. It shows the weak ventilation and perfusion status of the lung. Coming to inspiratory segment, this is phase 0, the downward slope after phase 3. And this is the beta angle. It is usually 90 degrees. It is the angle between phase 3 and the descending limb of inspiratory segment. Coming to volume capnogram, it is a pressure. In this capnogram, pressure is plotted against volume. The horizontal axis of the graph represents expiratory or inspiratory tidal volume and is generally divided into three areas. Phase 1, this is the anatomical dead space volume, and phase 2 is the transitional phase volume, and phase 3 is the alveolar volume. Sum of these three values is equals to tidal volume. Coming to recent updates, microstream technology, mainstream sensors, and ultra-compact micro-rotor technology. In microstream technology, it's for side stream sensors. It employs unique laser-based technology called molecular correlation spectrography as their infrared emission source. It has a small sample cell, which is and it uses a highly efficient and carbon dioxide specific emission source, which results in an extremely short light path. Because of this short light path, the breath sample can be greatly reduced to size down to 15 microliters compared to the sample cells used in conventional capnography. This small sample cell is useful in neonates who has high respiratory rate and small tidal volumes. In mainstream sensors, there is a plug and play module introduced by Respironics, and there are two versions, Capnostat 5, which is a new solid state mainstream sensor that is small and lightweight. It provides a variety of airway adapters to monitor adult, pediatric and neonatal patients. Another one is low flow. It's a new side stream sensor. It has a 50 ml sampling rate and has a new external sample cell that is attached to the patient interface. These Capnostat 5 and low flow sensors utilize same electronics, which makes them easily interchangeable, and it can be used in both non-intubated and intubated patients. Coming to ultra-compact micro-rotor technology, it was introduced to measure carbon dioxide, nitrous oxide, and other anesthetic agents. It can be used in either mainstream or side stream sensors using a 50 milliliter per minute flow rate and to monitor carbon dioxide at breath rates up to 150. It decreases the nuisance of obstruction resulting from moisture, water vapor in the sampling lines. Nomo line. It's a long life filter line that is more than 2 weeks, which actually dissipates water vapor from the within without the need for water trap or frequent replacements of sample lines. Coming to clinical application, EDCO2 is mainly used to confirm intubation and monitoring of sedation and ventilation inside the operation theatre. And it is also used to continuous monitoring of ventilatory status in the ICU or during transport of the patient. And in CPR, if ETCO2 is more than 20 mmHg at 20 minutes, it indicates higher chances of return of spontaneous circulation. And if the ETCO2 level is less than 10 mmHg persistently, then the quality of CPR should be increased. And to reduce intracranial pressure, usually carbon dioxide dilates cerebral blood vessels and increases the volume of blood inside the cranial vault. So ETCO2 has to be maintained between 30 to 35 mmHg to reduce the ICP. Coming to clinical aspects, ETCO2 will be high. Increased ETCO2 will be seen in fever, malignant hypothermia, thyrotoxicosis, bicarbonate injections, hypoventilation, respiratory center depression, neuromuscular paralysis, high spinal anesthesia, COPD and other neuromuscular diseases, rebreathing or exhausted absorber or faulty valves. Decrease in ETCO2 will be seen in hypothermia, hypotension, pulmonary hypoperfusion, cardiac arrest, pulmonary embolism, hemorrhage, hyperventilation, ventilator disconnection, esophageal intubation, airway obstruction, poor sampling line or leak around the ET tube. Coming to common waveforms that are seen, this is the normal normal ventilation in adults, and this is the normal ventilation in pediatrics with higher respiratory rate. Coming to shark fin appearance, it is caused by airway obstruction either due to mechanical reasons like tube kink or blockade by secretions of foreign body or pathological reasons like COPD. It is seen with increased alpha angle. And this is second waveform is the cardiac oscillations or ripple effect. It is a to and fro movement of expired gases at the sensor due to heartbeat, and it shows the to and fro movement in the inspiratory segment. Curare cleft. It is seen in phase 3. It indicates spontaneous breathing efforts by the patient or movement on the chest or abdomen. This is the esophageal intubation. It shows gastric washout of residual carbon dioxide and the ETCO2 becomes zero subsequently. The first waveform is the dual waveform capnogram. It is seen in phase 3. First peak is from the normal lung and the second peak is from the diseased lung. Example, single lung transplantation or endobronchial intubation. The second waveform is rebreathing. It shows elevated inspiratory baseline. Thank you.
Thank you, Dr. Aziba. It
Thank
was
you.
Taken exactly 15 minutes and finished everything in time. Thank you very much. Now I request Dr. Nagaraj to introduce the next speaker.
Okay, thank you, sir. Dr. Madhuri is our last speaker. Dr. Madhuri is a senior resident in the department, and she's joined the department just 6 months ago. She has shown considerable interest in academics and has already an international publication in her name. She's very knowledgeable when it comes to artificial intelligence, so we thought we should give her a thrust in her career progression and therefore have put her on this platform to talk on CVP monitoring. And I'm sure she will incorporate the role of AI in CVP monitoring. Over to you, Dr. Madhuri. Dr. Madhuri, are you?
Good evening, sir. Thank you for your gracious introduction. Sir, is my screen visible?
Yeah. Please carry on. Yeah.
I'm a senior resident in Akash Institute of Medical Sciences and Research Institute. My guide is Dr. Nagraj, sir. So today I'm going to talk about central venous pressure monitoring. These are the contents I'm primarily going to talk about. So what is central venous pressure? The central venous pressure is the pressure that is measured in the central veins close to the right atrium. It indicates the mean right atrial pressure, and it is frequently used to estimate the right ventricular preload. The normal value is 2 to 8 mmHg in awake patients and 8 to 12 mmHg in anesthetized patients with IPPV. So what does it mean? It means that usually in an awake patients, the spontaneous inspiration that creates a negative intrathoracic pressure that draws down the venous blood and into the chest and keeps the CVP on the lower end, that is 2 to 8 mmHg, compared to the patients who are already under anesthesia with positive pressure. It means that under anesthesia, where with IPPV, the positive pressure breath increases the intrathoracic pressure and transmit this pressure into the great veins. So the measured CVP level is higher. It means that it is around 8 to 12 mmHg, though the actual blood volume of the patient is on the normal level or remains unchanged. So what are the indications for keeping a central line? One is central venous pressure monitoring, pulmonary artery catheterization and monitoring, transvenous cardiac pacing, where we can insert a 6 French catheter via fluoro guidance and into the right atrium, which can be used further as a pacer. Next is the temporary hemodialysis, where this can be used for the patients who are having renal failure. Drug administration, especially the drugs which are irritable, which can cause thrombophlebitis, drugs like potassium, calcium chloride, amiodarone. So these kind of drugs can be given via the central line. Chemotherapy, for inserting a chemo port via the central line. Administering agents that irritate the peripheral veins. As just I mentioned, any dextrose, like high glucose solutions like 25% dextrose, 50% high sugar content drugs, or potassium, which irritates the peripheral veins, are preferably given in central line. Rapid infusion of the fluids, where you have to give a large volume of fluids, like 3 liters of fluids. It is difficult to give them in a peripheral veins because that can rupture with a high pressure. Trauma, major surgery, where we can expect a hemodynamic instability in the patients. So very large shift of the fluids can be there. Such patients also need a central line. Aspiration of the air emboli, where you have to take the air embolism, which obstruct the right ventricular outlet obstruction. Inadequate peripheral intravenous access and sampling site for the repeated blood testing. Contraindications, SVC syndrome, where there is obstruction in the above level and you can't give drugs in the emergency basis, because if you give the drugs, obviously the drug has to take collaterals to enter, and it takes long time to reach the site of action. So it's always preferable to select a femoral vein rather than the IJV or the subclavian in SVC syndrome. Newly inserted pacemakers, where the pacemaker sheets are quite big. So in such a places where you can't insert, or it will be difficult to insert a central line, that will be a contraindication. Pneumothorax on the contralateral side, where already there is a pneumothorax in the patient and lung is already collapsed. It's always advised to keep a central line on the ipsilateral side than the contralateral side, because if you keep or if there is a complication of pneumothorax while keeping the central line or post central line, the patient will be having a difficulty to breathe, because both the sides you develop pneumothorax. Coagulopathies, it's always advisable to insert an ultrasound guided IJV in patients who are having coagulopathies with the platelet values of less than 20,000 or less. Burns and cellitis at the side, because catheter inserted bloodstream infections are very much high. Aseptic precautions cannot be maintained. So these are the contraindications for placing a central line. Types of central line, we have tunnel catheter, non-tunnel catheter, peripherally inserted central catheter, big catheters, which are primarily used for giving long duration drugs, especially like anti-cancer drugs. Sites of insertion, we have jugular vein, subclavian vein most commonly, also femoral vein, cephalic vein, external jugular vein, brachial vein, umbilical vein, and basilic vein are also present. So if you see the advantages between all the 3 different common insertion sites, first one, we have internal jugular vein, which is very good for emergencies, like the similar with the femoral vein. And the advantage with the subclavian is it is very comfortable for the patient and it is good for the ambulatory purpose. So comparing to with all the different sites, advantages and disadvantages. First, internal jugular vein, it is an easy access, it has a lower infection rate. But the disadvantage primarily is carotid puncture and less comfortable for the patient. Next will subclavian vein. It is good for the long-term use, lower infection rate, but there is a very high risk of pneumothorax if you're going with the blind procedures. Femoral vein, again, quick in access in the emergencies, but it is a very high infection rate because of the sterility and limits the mobility also. The other veins are primarily used for inserting a PICC catheters for the long procedures. So first, internal jugular vein. As I just mentioned, it is an easy access. It has a short straight course with no wall but very few walls. It has a low pneumothorax risk compared to the subclavian, and right side is preferred to the left side because of the low thrombus risk and because of the short course also. The first major risk which we have to keep in mind is air embolism. So whenever we're keeping a central line in IJV, it's always advisable to keep a head low position in a Trendelenburg position. At least 15 to 30 degrees we have to place it. So under anatomical landmark guided approach, first keeping a central line with the anatomical landmark, we have three different approaches. One is anterior approach, central approach, and posterior approach. So primarily we use posterior approach or anterior approach. So in the anterior approach, the boundaries limit to the sternocleidomastoid muscle, the sternal head on the medial side, clavicular head on the lateral side, and the clavicle at the base. This is the anterior triangle. So at the anterior approach, we insert the needle along the medial edge of the sternocleidomastoid, and entry angle should be 30 to 45 degrees, aiming towards the ipsilateral nipple. So we need to palpate the carotid artery during the venipuncture, and the artery may be slightly retracted medially, so we can avoid with that. Next, posterior approach. This is the posterior triangle where we have the laterally external jugular vein medially to the clavicular head of the sternocleidomastoid and the mastoid process on the board on the posterior on the apex. So with the posterior approach, we have the needle to be inserted in the posterior edge of the sternocleidomastoid midway between the mastoid process and the clavicle around 45 degrees angle towards the suprasternal notch. So this is one of the most common method which we use regularly. Always we need to keep in mind the common carotid artery is always next to the internal jugular vein. So make sure that the backflow, everything has been checked when you're keeping the central line. For ultrasound guided CVP insertion, same. For any method of central line insertion, first we need to take the consent from the patient as it is an invasive procedure, explain about the technique and how we are doing it. So first we'll confirm the anatomy in the ultrasound. We inflate the vein with the Trendelenburg position Valsalva. Local anesthesia infiltration has to be given with the patient lying down and the head tilted towards one side. And we advance the needle under continuous visualization of the vein. And we need to make sure that we are keeping the artery in our visualization. And if better, it is always keep the artery onto the medial side. Using a dip shift method is one of the best way to insert an ultrasound guided central line. And we need to confirm with the venous return. Most commonly, we use the short axis way of visualizing the ultrasound guided CVP. And the only disadvantages with the short axis, we can't visualize the whole length of the needle. The tip will be visualized as a small bubble or a small dot. So we insert the guide wire under ultrasound visualization, we dilate the tract, and then we pass the catheter. So aspirate all the 3 lumen, and then we fix the catheter with a sterile dressing. What are the benefits we have with ultrasound guided central line insertion is there are very high successful rate, and there are very few complications like carotid artery puncture or anticoagulation of the patients. But the concerns we need to keep in mind is first we need to train the personnel, and then they need additional time for how they have to handle with the ultrasound. So this is a CVP set where these 3 lumen are present. Primarily, the white port is usually used for the CVP monitoring, which is the proximal port. The rest of the 2 ports we can use for giving any drugs or the fluids. Vasopressors and inotropes has to be given separately because vasodilators, it's always better to give them separately when there is a need to transfuse in different cases where the patient is having hemodynamic instability. This is the total contents where a CVP set is given along. Coming to the subclavian vein, as I just mentioned before, it is very comfortable with the patient, but the major risk which we need to keep in consideration is the pneumothorax. And other common one are the subclavian artery puncture and the air embolism, which is already noted before. Coming to the measuring of the central venous pressure, we have 2 different methods. One is manometers and transducers. The age-old classical manometers follow with the principle of a fluid column height, which indicates the pressure. And a transducer has an electrical signal converting the pressure into the waveform. So the main important thing which we need to consider while keeping a central venous pressure monitoring is the phlebostaxis axis, which is the level of the fourth intercostal space in the mid-axillary line while the patient is lying supine. So which pertains to the right atrium of the patient. So either the transducer or a manometer, which has to be placed next to the patient, it has to be lined along with the along to the height of the right atrium or the phlebostaxis axis to get the proper value of the CVP. So zeroing is the method where the readings has to be taken from the correct point, otherwise they will be inaccurate. The correct point is the source of pressure level at the right atrium, which is the phlebostaxis axis. So how do we use the manometer? Nowadays, we are not using much in the manometer method, but there are few places where they are using it. First, we line up the manometer with the phlebostaxis axis next to the patient and make sure the bubble is between the two lines of the spirit level. Then we move the manometer scale up and down to allow the bubble to be lined with a zero on the scale, which is called the zeroing here. So zeroing of the manometer. Then we turn the three-way tap off towards the patient and open to the manometer. We open the IV fluid bag and fill the manometer and to a level higher than the usual CVP expected. Then we turn off the fluid bag and open towards the patient. There, the fluid level inside the manometer should fall until the gravity equals to the central veins of the patient. So that value is the CVP of the patient, which can be measured. And we can turn off the manometer. Coming to the transducer, these are the equipments which are present in the transducer. One is a pressure bag, disposable tubing, transducer cable, the transducer itself, and the holder. So these are the parts which has to be primarily important and it has to be considered. All we have to set the transducer before preparing the patient for the insertion. Fill the bag with the, we need to explain, as I mentioned, we need to fill the bag with the fluid, and then we increase the pressure bag with the 300 mm of Hg, and make sure that the position should remain same for each measurement, and all the catheters has to be checked, and they have to be kept ready. And we tape the transducer to the phlebostaxis axis, and then first we turn the tap off towards the patient and opens to the air, removing the cap from the three-way port, opening the system to the atmosphere. Then we zero it so that the zero calibration will be done. And then when zeroed is displayed on the monitor, replace the cap to three-way and then open to the patient. So then you can see the CVP trace on the monitor. So what happens if there is an incorrect positioning? One is if the transducer is very low, this will give a very falsely high CVP reading. If the transducer is too high, it will give a falsely low reading. So always the phlebostaxis axis has to be maintained when you're keeping a transducer and when you're taking a CVP reading. So how does the waveform show on the monitor? One, we have different waveforms, which the CVP normal and the abnormal can be identified. So contents will be A wave, C wave, V wave, X descent, and Y descent. So A wave consists with the atrial contraction at the early and diastole, and the C wave is usually because of the tricuspid bulge, and X descent is because of the atrial relaxation, and Y descent is because of the end ventricular filling or the diastolic collapse. So these waves has to be noted in every waveform with the patient who are usually under anesthesia or who are in the critical care monitoring for the normal cardiac function and the hemodynamic stability to note. So for the abnormal CVP waveforms, we have different conditions which has to be kept in mind for the completion sake. So in atrial fibrillation, we have a loss of A wave, where you can see there is no A waveforms, just consecutively continuous waves are seen. And V waves, especially in the Y descents, are preserved. Atrioventricular dissociation, a Canon A wave can be noted. Tricuspid regurgitation, we have a tall systolic C wave and a loss of X descent. And cardiac tamponade, we have dominant X descent and attenuated Y descent, which is very important to be noted because we can expect a very high or shoot up of a CVP value can be seen. So what do you mean when the CVP values increase or decrease? So general conditions which has to be noted and kept in mind are fluid overload for the increases, fluid overload, right heart failure, cardiac tamponade, fluid effusion, tension pneumothorax, force exhalation, mechanical ventilation, decrease in conditions of hypovolemia, shock, and the forced inhalation. Clinical interpretation. First, we'll see the low values of the CVP. As I just mentioned, in hypovolemia, clinically we can notice rapid pulse, blood pressure normal or the low urine output, and poor capillary refill. So how do we treat it? First, we need to give fluid challenges with the rapid small boluses, and until the CVP rises, we need to watch. And if that it does not fall back again, if the CVP rises and stays back, but the urine output or the blood pressure does not improve, consider giving an inotrope. Next, low or normal or high. This is usually seen in the septic conditions where patient can have a vasodilatation because of the all the sepsis related agents which are creating the vasodilators, where the patient can have rapid pulse, signs of infection, pyrexia, and constriction or vasodilatation. So then we have to ensure the adequate circulatory volume is noted and consider inotropes or vasoconstrictors to be given. Next is hypovolemia, normal, though the CVP reading is showing up normal. So especially most of the anesthetized patients who are under IPPV, they might be showing with a hypovolemia, but the value will be showing in the normal ranges. Such time, we have to note with the rapid pulse, low urine output, poor capillary refill. So first we need to treat whatever we have seen, all the above. The venoconstriction may be caused by the CVP to be normal. So give the fluid challenges and observe for the effect as above. So always we need to keep in mind that the CVP graph will have an ascending limb as well as a flat limb. So once the ascending limb is, even though the value is showing some 6 mm Hg, it can be on the ascending limb or on the flat limb depending upon the contractile or compliance of the right ventricle. So a stiff right ventricle can have a CVP value of 6 mm Hg, but even after giving fluid challenges, it doesn't increase anymore. It means that it is already on the flat limb of the CVP graph. But in a hypovolemic patient, ascending limb, if you give the fluid challenges, they will definitely show a progression. Next one, with the high values, especially in the tension pneumothorax, as I just mentioned, we have a high CVP values. You can hear with the unilateral red sounds, resonant chest with the tracheal deviation, and the rapid pulse. So treatment is thoracocentesis and intercostal drain. Next, heart failure. We can see the breathlessness, third heart sound, pink frothy sputum. So according to the problem, we need to provide with oxygen, diuretics, and inotropes. Very high suddenly because of the pericardial tamponade, where there will be a difficulty for the heart to contract and pump the blood. So such time we can see the rapid pulse, muffled heart sound. So treatment for the pericardial tamponade is pericardiocentesis and drainage. Next one, for the pulmonary embolus or the high intrathoracic pressure. So whenever there is a high intrathoracic pressure, we need to make sure that CVP will be rising. That is because the intrathoracic pressure will transmit to the greater veins. So obviously, the thoracic pressure affects with the CVP also. So in such conditions, we will notice the high pulmonary vascular resistance, the left-sided pressure and the function may be looking normal. So a higher than the normal CVP may be needed to ensure the adequate venous return of the blood to the left side of the heart. In the left heart failure, so this is because of the resulting rise of the pulmonary venous pressure and the right side heart strain. So initially CVP will be normal, but there will be an increase in the significant failure. Constrictor pericardial is the same. That is like the paradoxical rise in the CVP on inspiration, and it is a fall on the expiration because of the opposite of a normal to the spontaneous breathing patient. So the absolute level will be higher due to the impeding filling of the heart. So this is primarily with the unreliable CVP readings. So both higher and the lower values can be noted in these three conditions. So we have to be having another options whenever we are suspecting with these three conditions, especially for pulmonary embolism or high intrathoracic pressure conditions. We have to keep another methods like assessing clinically or PV methods or SVV, or using a recent advanced methods like VEXs. For left heart failure, considering pulmonary artery catheterization is also one of the good method to assess for the left ventricular and diastolic pressure monitoring. The most common things which we consider after keeping the central line and we request is the chest X-ray of a patient to assess the placement of the central line position exactly. So malpositions are very much common after a placement of a central line. One is kinking. So if you see here, the left internal jugular catheter is not across the midline. So there is a kinking clearly shown at the site after the insertion. In this one, the first one, if you see, the ipsilateral insertion into the axillary vein has happened. And this has been given from the right subclavian, which directly went into the axillary vein. In the next one, there is a contralateral insertion into the right subclavian vein. You can see here, there is a small line. And the third one, there is a loop which is formed into the superior vena cava when the insertion is from the IJV. So there is a loop formation. There also you can notice. So these are the proper malpositions which has to be identified for any time after keeping a central line, be it in any method, blind method or ultrasound guided method. Always we need to check the position of the central line which is inserted, the catheter which is inserted. Complications, we have mechanical, vascular injuries, arterial, venous injuries, and cardiac tamponade, respiratory compromise, airway compression because of the formation of hematoma, pneumothorax, nerve injuries, arrhythmias, and thromboembolic events, which are very much common, and venous thrombosis, pulmonary embolism, arterial thrombosis and embolism, and catheter or guide wire embolism, infections, insertion site infection, catheter infection, bloodstream infection, endocarditis, and the misinterpretation of the data and incorrect use of the equipment. Coming to the key recent advancements, why do we need to revisit this CVP? So traditional CVP, as I just mentioned, it is a static measurement. So it doesn't use any particular value which is on the gradient level. So dynamic measurements have a different number which gives the clinical as well as the relatable level in a continuous measurement values. So it's always good to have dynamic measurements of the CVP for the fluid responsiveness compared to the traditional CVPs. In the recent advancements, we have various advancements which are in progression right now and which are in use in particular places. One is venous access ultrasound, one which has a multi-organ Doppler to quantify with the venous congestion. So what they do in this VEXUS method is they use the IVC size, they compare it with the hepatic, portal, and the renal venous measurements, where they will use the Doppler to see the size as well as the volume, and they grade according to the scale. One is grade 0, where the IVC first they'll check with the IVC value. If the IVC distensibility is less than 2 centimeters, that is considered as a grade 0. Grade 1, we have the IVC level is greater than 2 centimeters, along with the other Doppler effects like hepatic vein, where the S wave is is greater than the D wave, and mildly abnormal if the S wave is less than the D wave, and severely abnormal if there is a total reversal of the waveforms. That has to be considered. So individually, all the different veins are used with the Doppler. They compare and they form a scaling where the fluid responsiveness of the patient is assessed as a whole, all holistic approach with all the different measure, and it is a real-time ultrasound. So it is considered to be superior to the CVP, the traditional CVP which we are using. So as I just mentioned, this venous, as I just
Dr.
mentioned,
Madhuri, you've taken too much time. Please wind up because you've exceeded your time considerably.
yes, sir.
Yeah.
One is focus, and this is also the real-time ultrasound where we have the IVC diameter collapsibility, the cardiac function which we assess, and we can know if the heart function or the lung dynamics are all good. So if there is any complications or associating with the fluid mechanism, this can help with the knowing with the patient hemodynamic instability, especially if there is any pneumothorax or any pulmonary embolism which is involved. This is also one of the important advancements which you're using. Next is smart sensor integrated catheters, where we have a miniature pressure sensors embedded in the catheters. So once these pressure sensors is at the tip of the vein, so there is no long tubing artifacts which are there. There's no tubing mechanisms or anything. So we can get a continuous waveform or a capture. So it gives the real-time CVP waveform with the respiratory variations, cardiac oscillations, and the beat-to-bed pressure changes. and the trend analysis of the volume status and the right ventricular performance. So these are the newest advancements which are inserted into the catheter itself. There is no tubing or the transducer which is needed for these kind of catheters. And lastly, we have non-invasive or the variable approaches, where there's a small patch with the ultrasound uh, patches which are variable, and the machine learning approach models, they are placed on the IGV or a CCA, and they record the waveforms which, considering the cross-sectional area, the collapsibility index of the IGV, the venous distinctions, and the trend analysis are noted. So this is the most advanced with the right now with the present conditions. That's all. Thank you.
Thank you, Madhuri. Thanks for your extensive talk on CVP. Wish you could have confined to your time limit.
Thank you. Thank you so much for that lovely presentations. All the 4 topics have been covered in a very expeditious manner. Saturation, that is the SpO2, the temperature, the entitled CO2, and then lastly the central venous pressure. Very well done. I request Dr. Srikanthamurthy to make expert comments and then start the discussion.
No, as rightly pointed out in the beginning of it, to follow in all cases, irrespective of whether it is general anesthesia or
Yes.
or even MAC. The other 3 can be easily monitored, and it gives us so much of
Yes.
not only information, forewarning us would like to make.
Absolutely. Yes. Yes.
So
You're right.
it should be mandatory. It should be mandatory for all cases.
Yes, yes. We have the minimum mandatory standards in terms of monitoring the SpO2, blood pressure, the ECG, temperature, and then that CO2 in intubated patients. So beyond this, we have today we also covered the central venous pressure. So I just wanted to emphasize that in the CVP
for cases of long duration or patients with comorbid conditions, cardiac issues,
yes,
and where we expect a lot of fluid disturbances.
yes, fluid shifts. Yes,
It is in these cases that I think CVP is essential.
yes, yes, yes.
Apart from infusion of irritable substances.
Right. Yes. Yes. Comments from Dr. Nagaraj and Dr. Kodanha? Nagaraj?
The current generation probably have grown up with all these monitors beeping behind them continuously. Some of us, all the seniors who have done our post-graduation in the 70s and 80s know how hard it was to be in the OT for long lengths of time without any electronic devices for monitoring. All that we did was keep our fingers on the pulse and monitor the patient clinically. And now with probably we will not even start a peripheral vein without a pulse oximeter probe on the other finger. So it's made our life so much more comfortable. And the fact that the pulse oximetry and the ETCO2 monitoring have itself reduced the mishaps of anesthesia management by more than 90% shows how important the monitoring has been. So this, if there has been any revolution with respect to our practice of anesthesia, I think it is the monitoring devices that have made our life so much easier. Ram sir?
Yes. The topics covered deal with the basic monitoring which is required in day-to-day cases, which are very important and which should be combined along with, as you told, finger on the pulse. That is still very important because you can't always depend upon consistency in the values which you get from the monitors. Finger on the pulse is still an important monitor clinically. Regarding uh, the usage of these monitors, uh, we have to be very conversant with their limitations much more than their uses. So, because sometimes, as the speakers told, there may be false highs and false lows. So, we have to know about the troubleshooting in these cases. And one very classical example is like what Srinivas was telling about carboxy, the carbon monoxide poisoning. So in carbon monoxide poisoning, you will get a very high value of SpO2, but actually the partial pressure of oxygen will be very low. Similarly, in anemia, though the patient is very anemic, SpO2 will be normal only, but oxygen content is very low. So we have to keep these things in mind and not simply go by the values when we deal with these cases. Many of these topics which have been covered are also practical questions asked in the final examination, and they are also of importance as various in various viva stations for the students taking exam. So one more thing I wanted to tell about the pulse oximetry is when there are various fractions which are responsible for carrying oxygen, we don't get it by our usual pulse oximeter. So that is what's called co-oximeter. So with co-oximeter, we will be able to find out the various fractions which are carrying the oxygen, not only hemoglobin. Over to Nagaraj.
No, I have nothing else to add other than the fact that these essential monitors have become now part of our everyday work and probably will are getting more and more advanced, more and more miniaturized, and therefore they will now extend even to routine ward monitoring and not just confined to either ICU or ER or the ICU or the OT. Because the wearable devices of the ultrasound and real-time CVP monitoring will give a continuous and easy monitoring of central venous pressures even without invasive line. The AI into the monitoring devices as probably is the next exciting stage in our practice.
Dr. Murali, any comments?
Hello, am I audible?
Yeah, you are audible.
Okay. So, sir, should we conclude the session?
Yeah,
Hello.
you're asking me?
Yes, sir. I was just asking, sir.
No, if Dr. Murli could intervene and decide on that, please.
He's not here. I can't see him in the Zoom room, sir.
Yeah, Shreyasi, 1 minute. I'll
Yes.
call Murli that.
Okay, okay, sir, sure.
Hello.
Yes, sir.
Yeah, so sir line got disconnected. If any questions, then we can take it up, or else
Okay.
we can close the
Okay, sir.
meeting.
Let me check once, sir.
Yeah.
So there is no questions received still yet, sir.
Nagaraj sir, can we conclude the meeting, sir?
Certainly, sir. If there are no questions, we can conclude the meeting.
Yes. Yes. Thank you, sir. Thank you so much.
Thank you. Thanks a lot.
So thanks to all the dignitaries present here, Clarity is really glad to have all these brilliant people together in the session today. And I hope you all had a seamless experience. So with everyone's permission, I am concluding the session in here for today and looking forward to have you again. Thank you so much, sir.
Yeah, thank you, Shreyasi.
Thank you.
Very much.
Good night.
Good night.
Thank you all.